Greetings, everyone, and welcome to the 82nd session of the online Optom training series. Let me go and introduce to you our speaker for today. Today we have once again Dr. Priti Kamdar. She is an ophthalmologist, a glaucoma specialist from Mumbai, India. She completed her MBBS and post-graduation in ophthalmology from the Lokmanya Tilak Municipal Medical College in Mumbai, and she went ahead and completed her glaucoma fellowship from the prestigious LV Prasad Eye Institute, Hyderabad. She is blessed to practice as a glaucoma surgeon at Kamdar's clinic, as well as she practices at the Jasham Eye Institute. Dr. Kamdar's clinic is one of the oldest institute, about 99-year-old institute, where she practices and sees glaucoma patients in general. He is also an invited speaker as a glaucoma specialist at national as well as various international conferences, webinars, and symposiums. She is also an actively involved academician where she is teaching postgraduate students, and her special interests are in angle closure glaucoma, neovascular glaucoma, and glaucoma diagnosis. He has done a session with us on understanding or interpreting the shades of gray, which is interpreting the visual field. And today she is going to take it one more step further, where she will discuss some cases whereby perimetry was a useful test in terms of diagnosing and coming to a proper conclusion for that particular patient. So welcome again, Dr. Priti, onto our platform. Thank you so much for coming back and completing. It's kind of a continuation talk where you wanted to share some cases and we planned it out once again. Thank you so much for giving us your time again. And let me just leave the screen time to you.
Thank you, Mr. Fakhruddin, and thank you for the opportunity. It is always a pleasure to interact with students, and perimetry is one test which is very close to my heart. And so let's start. How do we use perimetry? Sometimes perimetry has been the one difference between me and the other ophthalmologists and has made all the difference to the patient. So I'm going to share with you 5 cases which will highlight the way we should use perimetry in our clinic. So coming to the first case. Now this was a 68-year-old lady. She complained of blurred vision in the left eye, which she has noticed since few months. On examination, vision was 6/12 in the right eye and left eye 6/12. So if you see on Snellen's, the vision was almost the same. The pressure was 21 in the right eye and 26 in the left eye. And just have a look at this video, because you will be answering a question relating to this video in the next slide. So what do you think this is? Just observe this. These are the pupillary reactions of that particular lady. So what do you think this is?
Majority 80% says it's RAPD. A few of them says reacting and brisk, as well as reacting but ill sustained.
All right. The answer is it's an RAPD. So RAPD is a short form or an acronym for Relative Afferent Pupillary Defect. And now I'm going to show you a real life which I just took. It is not the same patient, but it is exactly what you do. So this is a swinging torchlight test. Now if you see, yes, the right eye is dilating. Left eye is brisk. When you get the torch to the right eye, it dilates. Alright, so this, why I need to I put this slide is because RAPD is one of the tests which can tell you exactly where the lesion is. This is a schematic diagram of the pupillary right reflex. All of us know that the pupil is bilaterally represented. When I say bilaterally represented means when a light is shown onto the retina of the right eye, the optic nerve of the right eye carries it to there are some fibers which go to the pretectal nucleus in the brain, okay, in the midbrain. And these fibers from the pretectal nucleus go not only to the right sided right-sided Edinger-Westphal nucleus, but also to the left-sided Edinger-Westphal nucleus. That means both the pupils are going to react if only even one retina gets stimulated with light. So similarly, if the right retina gets stimulated and the right optic nerve is in perfect shape, you will get a pupillary reaction in both the eyes. So you have to remember, in this particular case, I will again run the video because it is important. This is a simple test which you can do in your clinics, and that is why, see now, here when the pupil constricts when it's on the left eye, it dilates. That means the right eye optic nerve is not sending impulses. And that's why when the light comes onto the right eye, the right optic nerve is not able to transmit the messages, and that's why the right eye pupil is dilating. So relative afferent pupillary defect is a very strong localizing sign. What does it tell you? It tells you the lesion is in the optic nerve. It is not beyond the optic nerve. It is in front of the pituitary. It's in front of the optic chiasma. I'll come to that later on. And both the optic nerves are unequally affected. So when I told you about this lady, and I said that this lady had an RAPD, means a RAPD of the left eye. That means when the light was shown onto the left eye, it did not transmit the messages. That means the left eye optic nerve was damaged. And now let me show you what her optic nerve showed. Alright, so I did a field for this. Now whenever you have an optic nerve involvement, you should do a perimetry. Now, so this is the poll question, for the next poll question, that describe this field. Is it a superior arcuate scotoma? Is it a superior plus inferior arcuate scotoma? Are these tubular fields? Is it an advanced glaucomatous damage? Whatever you feel best describes this field. You can use all the terminology, but whatever you think best describes this field is what you are going to answer.
Majority of them thinks it's an advanced glaucomatous damage, and there is a skewness between the superior arcuate, superior plus inferior scotoma, as well as tubular fields.
Yeah. So now one thing I can tell you is, I have not shown you the disc or the retinal photograph. So one thing I wanted to tell you is that just based on the field, you cannot say it's advanced glaucomatous damage. You have to see the disc. If the disc shows advanced glaucomatous damage, then you can label this field as having advanced glaucomatous damage. So this is not only a real thing, it's a viva question also, that whenever you are asked a field, you should never give the diagnosis. You have to say, you have to describe the field, and you have to say, I want to correlate it with the clinical picture. You will say it's an advanced glaucomatous damage only after seeing the disc of this patient. So this answer, even though technically when I show you the disc, it is correct, but for a viva question, that is incorrect. What I would say best describes this field is, it is a tubular field. Why would you say it's a superior arcuate scotoma? Because it's not only a superior arcuate scotoma. If you see the grayscale and if you see the actual values here, it's not only a superior arcuate scotoma, but it is also a superior plus inferior arcuate scotoma. So if you have to describe it, it could be superior plus inferior arcuate scotoma, but the best way to describe this field is tubular fields. So I would give both answers as correct: superior plus inferior arcuate scotoma and tubular fields. Both answers are correct. Now when I take you to the next, now you can say that yes, the optic nerve shows advanced glaucomatous damage, and now the fourth answer becomes true, that it is an advanced glaucomatous damage because it is correlating with the disc which shows advanced glaucomatous damage. So I hope you have got this one thing clear, that there was an RAPD because there is an unequal damage. It's a strong localizing sign. One. Second is, you should describe the field give a diagnosis based on the field only and only after seeing the full clinical picture, that is the retina, the optic nerve. All right. So now this is the end of the first case. Before I take you to the next cases, the next three cases, they are all neurological, and I wanted to first explain a basic neurological, the visual pathway. Now if you see, this is the optic nerve, the retina, all the nerve fibers from the retina, they travel into the optic nerve. We all know that they cross over. The temporal fibers do not cross over, but the nasal fibers cross over onto the opposite side, and then this is the chiasma where the crossing over occurs. Then this is the optic tract. After that, it goes forward in the form of optic radiations into the different parts of the brain, that is the pituitary, the parietal lobe, temporal lobe, and finally its destination in the occipital lobe. Depending upon where you have a problem, that is where you will find a field defect. I hope you have got this part very clearly. I will explain once again that there is a retina, the temporal fibers, nasal fibers, both together are into the optic nerve. Then they cross over into the chiasma, the nasal fibers. Then they go into the optic tract. You have optic tract, then the lateral geniculate body. These are called the optic radiations, where it travels through the parietal lobe, temporal lobe, and finally reaches the visual area in the occipital lobe. When each part is affected, it gives a peculiar type of optic visual field defect. What I was telling you is any defect which is proximal to the pituitary, here to the chiasma, will give you an RAPD. Anything which is in the optic tract or in the optic radiations will not give you an RAPD. So that's why I'm telling you again that a relative afferent pupillary defect, a very simple test to do in your clinics just with a torchlight, will tell you a lot about where the lesion is where the lesion is situated. Now, with this background, let's go to the second case. That is, this is a 57-year-old lady, and she complained of loss of vision in one eye since 5 years. She visited my clinic for refraction in the other eye because she felt her numbers were changed. When I checked her, her vision was in the right eye, no PL. In the left eye, 6/9 N5. So she enjoyed good vision to speak of. The last she had consulted an ophthalmologist 1 year ago. But the ophthalmologist just gave her the numbers, and they said that okay, right eye, we don't know why there is an optic atrophy, but there is nothing which we can do for the right eye, but the left eye seems to be okay. Now what I did was, this is the right eye which is no PL, and she has been operated also in that eye for a cataract, and if you see, it's a completely white disc, so it's a disc which is atrophied. We come to the other eye. This is the left eye, the left optic nerve. The left optic nerve looks pale. The vision is 6/9, but the rest of the retina was absolutely fine. There was no macular edema, nothing. Was there an RAPD? No, there was no RAPD. So now let me come to the next question. Which investigation would you advise? Would you do an OCT? Will you do fields? Will you do ERG? Will you do visual evoked potential? All of the above. What would you advise? So all of the above again seems to be the flavor of the season. So people feel that we should do VP, we should do ERG, we should do fields, we should do OCT. Now if there is one thing, I did not do any of the above. I just did a visual field. And first is, we have to know that when you advise a particular test, what are you looking for? So ERG, when you are looking for an ERG, when you advise an ERG, what are you looking for? So for that, you have to know what that test is going to tell you. VP, What is that test going to tell you? You have to have that knowledge. Now what I did is I did only the fields. I got to know that if you see, this is the blind spot and the temporal field is damaged more than the nasal field. So it means that there is something going on in the pituitary. At the level of the, when this is the level of the pituitary, and now I'll tell you. So some of you might ask that why did one eye become completely no PL and the other eye still has vision? So let me go back to to this diagram, and I'll tell you that here this was a sphenoidal ridge meningioma. And what is a sphenoidal ridge meningioma? What it does is, in a pituitary, it affects the center of this crossing. So both the nerves get affected to the same degree. But whenever it is not a pituitary tumor, but somewhere nearby, where it near the chiasma, what it does is it affects one eye first, so it atrophies. So here the sphenoidal ridge meningioma was near the right eye. It completely atrophied the right eye. It was somewhere here. I don't have the MRI picture, but it was somewhere here. So it grew, destroyed the right nerve completely, making that nerve no PL. Then it extended. As it grew further, it also compressed on the left nerve, damaged the nasal fiber first. So as a result, what was the clinical picture we had is that completely atrophied right eye and a partially atrophied left eye. But because we had the only one part of the hemisphere was gone, the patient still had 6/9 N5 vision. So unexplained vision loss, ERG, VEP is not what the investigation you should do. Visual fields is the indication for doing the test which should be performed in a person who has unexplained optic atrophy. So I hope I have answered and clarified that confusion, because we had unequivocal results. We try to play safe. Now suppose I had not got fields, the fields did not show anything. I knew, I was dead sure that the fields is going to give me the diagnosis. Then maybe I would have done an ERG. VEP only tells you whether that optic nerve is responding properly or no, and that is the test in optic neuritis. Was I suspecting optic neuritis? No, I am not suspecting optic neuritis in this person. So if at all my fields had come normal, then I would have done an ERG. Got it? So first fields, then ERG. OCT, because I could see the retina very, very clearly, I would not have done an OCT, because what is it going to tell me? I know that the nerve is atrophied. I know that the retina, the macula is healthy. So I would not do an OCT. It would be visual fields. If the visual fields had not showed me anything, I would have gone ahead and done an ERG. So let's go to the third case. This is a 40-year-old gentleman, and he has uncontrolled diabetes. He complains that he cannot see in a particular direction. All right. When he came to me, his vision was 6/6 N5. So here is a person, all these people, they complained I can't see in one eye. That was very, very clear. He complains I cannot see in a particular direction. He is not telling you the eye, he is telling you the direction. His vision is 6/6 and N5. So here you know you are going to do a perimetry. The question remains, what is the test that you are going to advise? Are you going to do a 30-2? I have not explained it further because we had taken this question and explained the other things in the lecture prior. So are you going to do a 30-2? Are you going to do a 24-2? Are you going to do a 10-2? Or are you going to check the whole field with a screening test? Let me just give you a little background. 30-2 checks the 30 degrees, 24-2 checks the 24 degrees, 10-2 checks the only the central field, the 10 and 120 is a screening test where you are shown one particular light. If you don't respond, it is seen as a blind as you can't see. So this is a screening test. So which one will you do. Alright, 53% feel that we should do a 120 screening test, and the rest feel that we should do either 30-2, 24-2, 10-2. Now let me answer this question. First let me show you what I did, and okay. I always do a 24-2 C test. I would do a threshold test. Whether you want to do a 30-2 or a 24-2 is an individual choice. So both answers in that sense are correct. But 10-2 you would not do. Why? Because you will get a very restricted field. And here is a person who's telling you I can't see in a particular direction. So his field effect is extending at least till his 24 degrees or 30 degrees, because that is our functional field. So I would say 10-2 should not be done. You can either do a 30-2 and 24-2, whichever suits you, both will give you results, and a 120 screening test is also going to give you results. But it will not tell you any improvement or any deterioration, because we sometimes use these fields not only to gauge what the current status is, but whether it is showing any worsening or whether it is showing any improvement. When you use a screening test, you lose that information, you lose that baseline. So I would say 30-2 and 24-2 will give you all the information that you require, plus it will also in future help you if you want to know if it is worsening or if it has become better with treatment. So I would say the 30-2 CETA fast and 24-2 CETA standard are the correct answers. 10-2 you should not do because it restricts your information. 120 screening test, yes, it's not wrong for diagnosis, but you will lose out on the other information when you want to follow up the patient. So what I want to choose is, yes, now I did a 24-2 CETA standard, and if you find that this is the right eye and this is the left eye, this is the right side of the right eye and this is the right side of the left eye. So if you have to describe this field, you will say it is a homonymous, whether it's a, one moment please, sorry, I gave you one answer. So just look at this field properly, and what do you think is the field defect? Is it a hemianopia? Is it a homonymous hemianopia? Is it a homonymous quadrantanopia? Or is it a bitemporal hemianopia? How would you describe the scotoma? So if you see homonymous hemianopia, what do you mean by homonymous? Homonymous is when the same side of the field is affected. For example, in this field, the right side of the right eye is affected, and in the left eye, again the right side field of the left eye is affected. So that is, so it's very clear that it is a homonymous. The right side, the same side of both the fields have been affected. So this is a homonymous defect. What is hemianopia? Hemianopia is when a complete quadrant is, a complete hemisphere is gone. In here, it's vertical. It is called hemi. When only a quadrant is affected, it is called quadrantanopia. So here the correct answer is homonymous quadrantanopia. So it is not a hemianopia, it is certainly homonymous, but it is not hemianopia because it is not completely affecting the half of the field. So this is, and what is bitemporal? For those who have answered bitemporal hemianopia, you have to remember bitemporal, the name tells you. If the temporal field of the left eye and the temporal field of the right eye are affected, then it is called bitemporal. So this is not a bitemporal hemianopia, it is a homonymous field defect, but it is a homonymous quadrantanopia. And let me now go back to the, yes, here. So when do you get a quadrantanopia? You get a quadrantanopia whenever anything is in the optic tract or in the parietal lobe or in the temporal lobe. So this is a localizing sign that you will get quadrantanopia if you are in the optic tract or you are in the parietal lobe or in the temporal lobe. Alright, and so you will know without even doing an MRI where exactly it is. Now I will just now introduce one more term, congruous and incongruous. What is congruous? When they are exactly similar, they are called, it is called a congruous defect. When the right side defect and the left side defect is exactly similar, it is called a congruous defect, and when they are not exactly similar, it is called a incongruous defect. Now in this particular it is exactly similar. If you see, it is sparing the central spot here, it is sparing the central spot here. If you see, it has a very similar pattern. So this is a congruous homonymous quadrantanopia, and you will find that it is affecting the right side. So it is called a right sided. It does not describe the eye, it is defecting the side. So it's a right sided congruous homonymous quadrantanopia. This is the complete description of this defect. So we have answered that question. We'll go to the fourth case. This is a 45-year-old male who came to me, and this is one case which if I had missed, I would not have even known. So this is a 45-year-old male. He had actually come to me for his wife. It was his wife who was the patient, and he said, oh, if I've come for her, let me also get examined. And he was struggling to get adjusted to his progressives, and it was nothing new. We see so many people that they keep on fiddling with their progressives, I can't see, and they keep on complaining. Now when I did his refraction and with his glasses also, he was 6/4 and 5. However, during refraction, I do my own refraction, and this is one reason why I have realized that I am right when I do my own refraction, that it's the single most important test that you can do, and that is what you all do day in and day out. So that's what I am saying, that he had 6/4 and 5. During refraction, he said that the outer letters of the 6/4 line were hazy in the right eye. This was his only and plus that I don't like progressives. This is what sent the alarm bells tingling, and now I am asking you, which test will you do when somebody says, during, you're talking about distant vision. When in a distant vision somebody tells you that in the 6/4 line, the side test is a little, the letters are little crooked. What will you do? Amsler's test, OCT, color vision, fields, all of the above. What will you do?
So majority of them say that they would do AMSLers.
Yes, that's a good thing. Fields, color vision, OCT. Now, let me tell you what Amsler's does. When you are doing an Amsler's test, you are using your central 10 degrees. Alright, and when you are looking at a distant object, like when you are using the Snellen's chart to check vision, you are using a wider field. That means you are using at least a 24 degree or at least a 20 degree field. So when on an Amsler's test a person says that I see things crooked, that is when, and this person did not say that when he was reading, he said that only when he was looking at a distant object. So Amsler's test you are perfectly justified in doing, but you realize that Amsler's test will be normal because his central field is not been affected much. Or rather, let me put it other way, if his central field is affected, only then you will get Amsler's test positive. Alright, and when he is not had that complaint while reading, that means probably you will get an Amsler's test negative, but you are perfectly justified in doing an Amsler's test. The first test I did for him was perimetry. Why? Because when a person says in one eye I am seeing the things crooked, OCT you are justified, because OCT, if you have epiretinal membrane or if you have a SRNVM or you have a neovascular membrane or macular degeneration, it will be picked up on OCT, but then all the letters right from top to bottom will be distorted. It will not be only the last line or the 6 by 4 line which will be distorted. You got it? So this is, I am telling you, you are perfectly justified in doing an OCT also if you have an access to OCT. But the first test you should do when a person says this is visual fields. Alright, you can do an OCT. If the visual fields come out normal, then you should go to OCT. The Amsler's test could be the first test you do. So as I said, there is nothing right, nothing wrong. So I would say in the order of preference, I would do Amsler's test maybe, then fields, then OCT. Color vision may or may not help. Color vision helps when a person actually has blurred vision, or when the patient says that I can't see clearly. So color vision is the last test you would do, and all of the above, if you have access to all those tests, you can certainly do that. So if I have to say which is correct, I would say the fields is the first thing you should do. And what did I do? This is the disc. Now I am showing you the disc. The disc is perfectly healthy, and what I did was this. So this is one of the I did a fields. This is one of the earliest pituitary tumors I have picked up, and from that I have realized three things. That sometimes people say, oh, you can have optic nerve pallor and normal vision, and then you do a field and you will be surprised that there is a field defect. I say no. First you will have a field defect. If you have a pituitary tumor, the first thing you are going to have is it will affect your vision. Only the affection of vision will be so subtle, as it was in this case, that you will not even realize that the vision has been affected. So first it affects your vision, it affects your visual field, and then it will go and cause visible damage to the optic nerve. If you see here, there is no visible damage to the optic nerve, despite the fact that you have an advanced field defect in the right eye. So you will realize that, remember, if you have an optic nerve defect, it will first affect your vision, but you will have to be very, very alert to pick up the changes in the vision, to pick up what the patient says, and then it will affect your optic nerve. Even one exception is glaucoma. Apart from that, all other things, they will first affect your vision and then they will reflect into your optic nerve. In glaucoma, it will affect your optic nerve first and then it will affect your vision. Visible, when you are checking vision, it will affect your field, mind you, but your vision will not be affected in glaucoma. So I hope I have made this point clear. That again, now one more thing, I was talking to you about congruous and non-congruous. Congruous means when it is exactly similar in both eyes, it is called a congruous defect. And if it is not similar, it is called incongruous. So this is a defect. Here it is a dense hemianopia. So to those who were confused between quadrantanopia and hemianopia, this is a hemianopia where half the field is affected. Okay, is it congruous? No, it is incongruous, because if you see the left eye, the field defect is not exactly similar to the right eye field defect. So this is a non-congruous bitemporal hemianopia. So this is the best way to describe this defect, and it's such a beautiful localizing sign that it tells you that it is the defect is in the pituitary, nowhere else. Nowhere else will you get this kind of a defect. The defect is in the level of the pituitary gland. I hope I have made this point very clear. And now I come to the last case, that is the fifth case. Again, these were all very, very young people. 48-year-old patient, he came to me with the history of sudden loss of vision in the left eye 2 days ago. Right eye vision is 6/6, left eye vision is 6/36 N18 RAPD. The moment I have an RAPD, I know that it's an unequal affliction of the optic nerve, one, and second is it is proximal to the optic chiasma. So I already know where my defect is, where my pathology is. So it is in the optic nerve, proximal to the, and it is only affecting one eye more than the other. So these are the two, this is the information which I immediately get when I do this simple test called an RAPD, and this is the disc, and all of you will agree that there is an edema. The nerve is swollen, it's edematous. Now what is the differential diagnosis of an edematous nerve? It can be papilledema, it can be non-arteritic ischemic optic neuropathy, or it can be optic neuritis. In this case, it was not bilateral, and that is why I am saying it is not papilledema. Alright. One more thing, that papilledema, and it affects both nerves, and that is why you may not get an RAPD with papilledema unless there is a unilateral papilledema, which is very, very rare. Okay. So because there was a RAPD, because there was a unilateral affliction, I am saying it is not papilledema. So the differential diagnosis is it is optic neuritis or it is non-arteritic ischemic optic neuropathy. I hope you are familiar with this term. Optic neuritis is an inflammation of the optic nerve, and arteritic ischemic optic neuropathy is where the blood supply to the nerve suffers. So both are completely different. And why do I want to differentiate between optic neuritis and non-arteritic ischemic optic neuropathy? Why? Because optic neuritis has a very, very good prognosis. NAION does not have a good prognosis. In NAION, the defect always remains. It may improve with time, but the defect remains a slight visual defect. Even when the patient sees, here patient has come with a visual prognosis of vision of 6/36. His vision is going to remain impaired if it is an ischemic optic neuropathy. The treatment for optic neuritis is intravenous steroids. The treatment for ischemic optic neuropathy is not so very well defined. So I need to make a diagnosis whether it is optic neuritis or whether it is ischemic optic neuropathy when the patient comes to me. Why? So I can prognosticate, I can treat the patients properly, and I can also tell the patient what to expect. So that is why the fields, and which is that one test, color vision will be impaired in both, the the OCT will be impaired in both, in the initial stages, MRI will show disc edema in both. So the only localizing test I have to differentiate between optic neuritis and ischemic optic neuropathy is a field, and the field will clinch the diagnosis. This is an altitudinal defect. Now some of you might also say that this is a superior arcuate scotoma, and you are not wrong. But the way the one half is completely gone, this is a altitudinal defect. Now there is a confusion here because the entire upper hemisphere has been affected. Many times you will find that there will be a clear-cut demarcation at this level or at this level or this level, and that is when it becomes a classical altitudinal defect, and a classical altitudinal defect is diagnostic of ischemic optic neuropathy. So in this case, if you were to say why is this not a superior arcuate scotoma, I would say you are right, that you can describe it as a superior arcuate scotoma, but with the disc picture what it is, this is nothing but an altitudinal defect, and an altitudinal defect is the hallmark of an ischemic optic neuropathy. You can have other kinds of defects also in both optic neuritis and ischemic optic neuropathy, but this is a strong prognostic indicator. With time, this will become better. This defect will become better, but the patient's vision will not recover completely. He will always feel that the left eye is not as good as the right eye. He will always feel that, whereas in an optic neuritis, when you initiate intravenous steroids, their vision may completely recover and they may not have any visual field defect. Visual field defect and even visual defect. He may not perceive that his both eyes are different. So when you are going to treat this patient, you will say, doctor, you've treated me. He might say, doctor, you have treated me, but I still feel that my left eye is not as good. So you will have to prognosticate. This will help you tell him that whatever treatment I do, your vision may not come back to normal. It may recover, but it may not come back to normal ever if it is an ischemic optic neuropathy. So these are the cases, these are the representative cases where I was helped so much by perimetry, and that's why I have shared them with you. And now this is the end of my presentation, and the take home messages which I am telling you is unexplained vision loss is one condition where perimetry helps in clinching the diagnosis, as in the second case where one eye had a optic atrophy. He had been to ophthalmologist earlier, and because her vision was good, they did not think of doing any additional tests. Why? Because the patient said that why should I do a test? Anyway, you are saying that my right eye vision is not going to recover. We have to do the test to find out what is the left eye, is it at any risk? Okay. So unexplained vision loss, perimetry clinches the diagnosis, makes the difference between you and all the others. Second, RAPD, a very simple test with unilateral vision loss, is a strong localizing sign. Without doing any other test, you are able to find out where the problem or the pathology is. 24-2 or 30-2, whenever you are doing a field test, is a threshold test should be the test of choice, because it gives you the luxury or the advantage of also monitoring worsening and improvement. All right. And with this, I thank all of you for a very patient hearing, and this is my staff, my husband, and the lifeline of my clinic, who help me help patients, and I'm so indebted to them. With this, I thank again Mr. Fakhruddin for giving me this opportunity, and we can now take any questions if there are any.
Thank you so much, Dr. Priti. I just wanted to get your thoughts on this, because we as primary eye care practitioners, right, we always are doing refractions. That's the
Right.
bread and butter of being optometrists.
Right.
Again, with that thought, we also are really doing preliminary examination. That
Right.
means pupil examination, as you said, do just by looking at the pupils.
Yes.
I mean, you cannot re-emphasize more, and I can't agree to you more than what you have told, that doing a pupil test does not take much of a time, but it gives you a lot of information in terms of what's happening beyond the retina, right?
Right. True. Very, very true. So these are things which you can in India. See the involvement of optometrists is very different all over the world. In India, those who work in a where you prescribe glasses, you are used to doing refractions, and those who help us in our clinics, they sort of help us in clinical practice. But in US, and I don't know about what the role you play in Malaysia, but in US they are almost like ophthalmologists. The only thing that they can't do is they don't operate and they can't prescribe, but they are the primary people who diagnose. So I don't know how, in Malaysia, what is the status or the rest of the world, but I would say that even those many people in India, they feel that the patients, they will first go to an optometrist and then to get their glasses checked, and then they come to us, because the optometrist there has directed them that no, your eye is not all right, you go to an eye doctor. So I would say that the role played by an optometrist is so important as a primary worker.
That's right.
So
Yeah.
that's how. So even in India, they can certainly learn just a pupillary reaction, and they will know exactly where to refer the patient.
Yeah, that's true. And according to the World Health Organization definition of optometrists throughout the world, I think it tallies through. We need to actually look at, not only refraction, we need to look at eye health. So we do learn all these tests in our curriculum.
Yes, yeah, I know.
It's
Yes. We have students, no, we have students coming from different optometry schools. They come as interns here, and that is how I know KUR. So we know that they are very good in diagnosis also. Only thing is, when in India, when they go to a to dispensing, they lose a little bit with the clinical. It happens. But RAPD can be checked anywhere. That's what I'm saying.
Yeah, you don't need any special instruments to do that. You just need a torchlight, which you will have. Because
That's
when
right.
you're doing, the markings of progressive in the optical center, you will have a torchlight anyway.
Exactly.
It's
Exactly.
nothing new which you need to invest a couple
Yes.
of dollars to buy that. It's not going to be that way. So,
Right.
and the other thing which I really would like to get your opinion on, because most of us probably who are working in their own practice, or if we are working in an optical store, we would not have an access to perform a visual field test. So the idea is we can definitely refer the patients for doing the visual field test. But what's your take on performing gross visual field examination, like just doing a confrontation, so that when you
Okay.
compare your field with the patient's field, you can at least know what's going on wrong? Because the cases what you discussed are, they are having obvious field defects which you could get on confrontation.
Yes. Yes. So now the lady, I showed I showed 5 cases. The first case was glaucoma, and there, yes, confrontation would have worked. But again, after that, what?
Yeah.
So you have a person who's telling you my vision is not clear. So it cannot be only confrontation. You have to do it on a field testing.
That's right.
And if it is not something gross, for example, now bitemporal hemianopia, the last case which I told you, there, yes, probably he was 6/4 vision, N5. There it would have worked, because
Right.
here is a patient who's not telling you that I have blurred vision. So if you have blurred vision, you cannot do a confrontation test. You should do it on a field testing. But if you have a person who is not complaining and you just assume that he has an advanced disease, then it will work. Again, early disease you will miss.
Yeah.
Yes. So I would say that we should not do confrontation. If you have the slightest doubt, refer.
Refer them.
Yes.
Okay, okay, good. Thank you for your thoughts. And we have some questions pouring in. So I'm just gonna show you this question and we'll get some thoughts about that. What about the treatment of NAION? Is there any treatment, or what would be your preferred choice of treating this?
Okay. So NEION stands for non-arteritic ischemic optic neuropathy. What do you mean by non-arteritic? Now there is something called as arteritic ischemic optic neuropathy. Arteritic ischemic optic neuropathy is a life-threatening disease. It means, and it is not commonly seen in Asians and Indians. And what it means is it causes inflammation of the larger blood vessels. So you have to differentiate. One is between arteritic ischemic optic neuropathy and non-arteritic ischemic optic neuropathy. One way is temporal arteritis is a form of anterior ischemic optic neuropathy, and the vision loss is much more severe. You will find that if you just, there is a temporal artery here, if you just roll your finger on your temple, you will find a thickened artery, and that is the one which is diagnostic for ischemic optic neuropathy, arteritic ischemic optic neuropathy. So then immediately you have to refer him to a physician, because within a week his other eye will get affected and he needs to be treated with intensive steroids. So this is arteritic ischemic optic neuropathy. Non-arteritic is one where the smaller blood vessels are affected. But the same thing which can affect one eye can also affect the other eye. So the other eye, one is you have to prognosticate to the patient that your other eye might get affected. And so we do not have any treatment for ischemic optic neuropathy. You can give steroids. So the associated inflammation, you cannot correct the ischemia, the lack of blood supply, but whenever there is an injury, there is also an associated inflammation. So that inflammation may get corrected and you can save a few nerve fibers by giving steroids, but we do not have any definite way of completely treating NAION. One. Second is, but however, why do you need to investigate them more? Why? Because most of the times, whatever has caused the ischemic optic neuropathy in one eye will cause it in the other eye, and that is uncontrolled blood pressure, then a sudden drop in blood pressure when they are sleeping at night, so nocturnal low BP. So these are the tests, and there are small thrombi which are being thrown up, so they have to do an echocardiogram. So all these tests have to be done to diagnose the cause of the NAION and treat that cause. Whatever you do, the vision is never going to completely recover. The recovery is most of the time based on the patient's response. So if you correct the high blood pressure, he will recover a little bit. If you correct the nocturnal dip, he will recover. You place the patient on blood thinners, it will not affect the other eye. So we don't have any definite treatment for it except for steroids, but we do investigate to prevent a repeat and to prevent the other eye affliction. Got it? So I hope I have answered that question.
That's right. And co-working and co-management with other specialties, like as you said, it's towards blood pressure related. So working, especially in that area, would also help.
Sorry.
Patient. Working together with
with the physician, because the physician doesn't know. They will say, "Kya hua?" I mean, what is wrong with your eye? You have to tell them what to look for. That I am looking for a low BP. They are never concerned with low BP. They are always concerned with high BP. And we say we don't want the BP very low because this is what is affecting them. So that is why you have to talk to them and tell them what you are looking for. That's all.
Correct. Yeah. And let's look at the other question here. Could you please tell us the use of VEP in optic neuritis? How would VEP help?
Okay. In fact, VEP is the test done for optic neuritis. What is a VEP? It's a visual evoked potential. That means if I put a flash of light on your eye, your optic nerve is going to carry some signals. Your retina is going to carry some signals. Those signals go to the brain and they are recorded. And that recording is called visual evoked potential. There is a certain waves, there are certain waves which occur in optic neuritis, and they are called the P waves and the N waves. In optic neuritis, one particular the wave is stunted in height and plus prolonged. When you do VP, it's diagnostic of optic neuritis. If the N wave is delayed or the P wave is delayed and it's stunted in height, the P100, which is it's called, that is diagnostic of optic neuritis. So if you have a confusion, you can do an MRI, you can do a VP, you can do fields, and all this will tell you whether it is optic neuritis or whether it is ischemic optic neuropathy. However, the diagnosis for optic neuritis is now MRI, visual evoked potential and fields. These are the three things which help you diagnose optic neuritis from other conditions. Okay.
Yes.
How to differentiate between optic neuritis and optic nerve head drusen? That's a very good question. One is that optic nerve head drusen will not have any vision loss. Optic neuritis will also give you an impression of disc edema, and optic disc drusen will also give you impression of disc edema. However, optic neuritis will have little visual disturbances. One, optic drusen will not have visual disturbances. Second, optic nerve head drusen are bilateral most of the times. Optic neuritis, though it can be bilateral, but it usually is a unilateral phenomenon. Color vision in optic neuritis will be affected. It will not be affected in optic disc drusen. If you want to do perimetry in an optic neuritis, you may have different scotomas, and optic disc drusen may just give rise to enlargement or scotoma around the blind spot. Then if you want to do OCT, you will very clearly be able to see that in optic neuritis, the cup becomes very small. In papilledema, the cup completely disappears. So most of the time, we have to differentiate between papilledema and optic disc drusen, because papilledema is bilateral, optic disc drusen are also bilateral. But you will see in papilledema the cup will completely go away. So even the appearance of the disc will be full, and in optic nerve head drusen, however, you will get a cup. So I'm telling you differentiation between optic neuritis, papilledema, and optic disc drusen, all three. So in papilledema, color vision may or may not be affected. So it's more important to differentiate between papilledema and optic disc drusen. So papilledema, again, you may not get any field effects, you will not get any color vision disturbances, but you will get other symptoms, like say headaches. You will get little visual disturbances probably, but the main thing is in a papilledema the disc is completely obliterated. In optic nerve head drusen you will get a cup, and also if you do an OCT you will be able to see the drusen very clearly on OCT. And if you still have a doubt, then you can do a sonography, and the sonography will also show you the drusen very clearly. So these are the ways you differentiate between the disc pathologies.
Okay, thank you so much. And one last question before we could end this. There has been some patients in this perimetry was also done, and normal intraocular pressure was seen. The
Okay, fine, all right. Perimetry normal, IOP normal. I have seen patients that do suggest check perimeter after 3 months.
Yeah, yeah. So what's your thought?
Many patients with a high cup disc ratio. Now, probably when you say a high cup disc ratio, perimetry normal, IOP normal, this is probably a physiological cupping. Now, we have been traditionally taught that you have to describe the disc in terms of cup disc ratio, means the empty space to the entire size of the disc. This is one drawback of describing a disc with a cup disc ratio, is because a 0.8 cup in a large disc may be completely normal, and it's like a donut. If you have a small donut, you will have a small central space, so the cup disc ratio will be smaller. And if you have a large donut, you have a large empty space, so you have a larger cup disc. A 0.8 cup disc ratio with a completely healthy neuroretinal, whereas in a small disc with just 0.2 cupping also you could have damage. So when this person where you are referring to, cup disc ratio high, perimetry normal, IOP normal, probably you are dealing with physiological cupping, means the disc is very large, and that is why the cup disc ratio is very large. So this is what it probably means, and because it is normal, I would also advise that you come after 1 year. That is what I would advise. I would check the perimetry after 3 months only if a person has glaucoma or has progression. Even if I have a person who is a glaucoma suspect, I would not do perimetry after 3 months. I would do it probably after 6 months to a year. That's how it is.
Okay, great. Okay,
Yes.
great. So I think we have taken almost all questions, Dr. Preeti. Thank you so much for giving us your thoughts, giving us the time.
Oh, and thank you so much for the opportunity. I love teaching, and so it's been a great experience for me too. And I'm thankful to all the students and our audience. So all the best to you for all these sessions that you're doing. It really helps a lot.
Most welcome.
Okay.
And we'll try to keep doing our best as we can. Just for the attendees, we do have case presentation series lined up. So if you have any interesting cases, please feel free to submit your abstract, and the scientific committee will look into it and schedule your presentation, and you can present on our platform. Just want to let the attendees know that we do have sessions planned next week. We have session again, one on glaucoma series on evaluation, and one on specialty contact lens, how contact lenses help for visual rehabilitation. Thank you so much, and I will see you all next week. Good day, take care, and bye-bye. Thank you, Dr.
Thank you. Bye bye.
Bye.